Welcome back to the What's in Your Head podcast, Tools for Pain and Dizziness. I'm Pete Schultz, Doctor of Physical Therapy. Hip and knee pain are among the most common reasons people seek medical care. Many individuals are told early on that they'll eventually need a joint replacement, often based on imaging that shows arthritis or cartilage loss. Others are told there's nothing to do until the joint gets bad enough for surgery. The problem is that imaging doesn't tell the full story. You could have significant arthritis and function quite well, or you could have a lot of pain with very little structural damage. Pain and joint damage are related, but they are not the same thing. The decision to move forward with a hip or knee replacement shouldn't be based solely on an X-ray or MRI. It should be based on how your symptoms are affecting your daily life, your ability to walk, sleep, sit, work, exercise, and do the things that matter to you. In this episode, we'll talk about what hip and knee osteoarthritis actually is, the difference between pain and damage, the range of non-surgical and surgical options, what you can do now, and ultimately, how to know when it's truly time to consider a joint replacement. At the end, I'll even share my own experience of having a joint replacement at 39 years old and what helped me finally decide when to have it done. Hip and knee pain are some of the most common orthopedic issues that people seek care for. So you go into the doctor's office with bad hip pain or bad knee pain. The doctor is going to do imaging, they're going to do x-rays, and then some of the things they'll say are, hey, maybe down the road you'll eventually need a hip replacement, or there's nothing you could do to grow that cartilage back, or physical therapy won't necessarily help you, you're just going to need a joint replacement one day. While that might be true, there are things you could do, and today we're really going to talk about all the options that you have when you have hip and knee osteoarthritis, what osteoarthritis is, and what you could do in the meantime. Maybe eventually you will need a hip replacement, but after this episode, you'll have a better idea of when to pull the trigger and when to finally decide the right time to have it done is. Physical therapy may not be able to fix the structural issue going on with the hip, but it can help improve your mobility and improve your strength, give you guidelines for exercise, and ultimately help you decide when to get the surgery if necessary, because that decision is based on functional limitations and how much those limitations or that pain is interfering with your life, not solely based on your X-ray or MRI. Now, there are exceptions. There are things like avascular necrosis, which is decreased blood supply to the femoral head. And there's something called acetabular protrusio, which is when the socket wears down so much that the femoral head is pushing through, or fracture, stress fracture. So there are some reasons that are solely based on the MRI. If an MRI shows one of these things, that should help you decide to get a hip replacement at that time or a knee replacement at that time. But for the most part, we don't use x-rays or imaging alone to decide when to get the surgery. So let's talk about what hip and knee osteoarthritis is. Osteoarthritis is a degenerative joint condition involving cartilage changes. It's really normal degenerative process where wearing down of the cartilage, and it's a normal part of aging. So it's normal. As you're younger, you're playing a lot of sports, you're running around, you're jumping, people who do a lot of exercise, you're going to get wear and tear of these joints. You get wearing down of the joints, which is normal degenerative changes. Then sometimes bone remodeling occurs when cartilage changes advance to the point where it has gotten a lot worse. You could get bone spurs and you could get changes of the surface of the joints. And then you're going to get some inflammation of the joint and the surrounding tissues. And that's where you're going to get some some inflammation of the tendon and the joint capsules and some of the structures around the joint. Then ultimately, there's pain associated with it. But it's important to know that the pain comes from the nervous system. And you could have advanced osteoarthritis with minimal pain. You could have no arthritis, and you could have totally clear imaging with a lot of pain. So we have to know that the pain doesn't necessarily equal, the amount of pain you have doesn't necessarily equal the amount of damage that there is. I've seen both of these situations, and we're going to get deeper into that conversation in a few moments. Hip and knee osteoarthritis is one of the most common chronic musculoskeletal conditions worldwide. It increases with age, but we are seeing people younger and younger with osteoarthritis, especially with athletes like gymnasts, figure skaters, hockey players, ballet dancers. These sports that have a lot of impact on the joints, they're going to wear out. They're going to wear out sooner. Some of the common risk factors, obviously age. As you get older, it's more common to have osteoarthritis. Prior injury or surgeries. Some injuries or surgeries in the hip and knee kind of progress the arthritis a little quicker. If you've had a meniscus tear in the knee, that might advance your arthritis a little quicker than it would have if you didn't have that injury. Or if you have a labral tear in the hip, which everyone has labral hairs in the hip. But if you have a labral tear in the hip, or you have some bony changes around the acetabulum or the femoral head and neck, that may cause some advancing of osteoarthritis. Also, there's a genetic component. Some people are born with less resistant cartilage and it fails quicker under heavy loading. Or some people are born with hip dysplasia, which is a shallow socket or a shallow acetabulum. Or some people are born with femoral head or acetabular bony abnormalities like femoral acetabular impingement, where the changes in the bone shape is going to lead to excessive wear and tear of the cartilage. And then there are other things like joint laxity, people who are double jointed or hypermobile, that could lead to increased joint forces, causing more breakdown of cartilage. Then we have to look at lifestyle factors like obesity. That's a mechanical situation where if you're 20 pounds overweight, picture walking around all day with a backpack that weighs 20 pounds. If you walk around the city all day, you're going to have some aches in the hip and knee joints. Being a little bit overweight is definitely going to increase forces to the hip and knee joint. And then occupational and sports demands. Looking at occupational and sports demands with your gymnasts, ballet dancers, hockey players, figure skaters, construction workers who work on flooring and carpet, plumbers, electricians, farmers, miners. I don't see a lot of these people in New York City, especially the farmers and miners, but any of these manual labor jobs or manual labor professions are going to have some more wear and tear on the joints than the people just sitting in an office all day. Then you have other people like postal workers, people who work at warehouse and factories, who do heavy lifting, people in the military, firefighters. These more physical jobs with increased loading, people will tend to wear out their hips and knees a little quicker. Then we look at the economic burden of hip and knee osteoarthritis. Hip and knee osteoarthritis are a major driver in healthcare costs, disability, and lost productivity. There's billions of dollars spent annually on imaging, injections, therapy, medication, surgery. And there are, just so you get a picture, there are about 800,000 knee replacements performed in the United States every year, and there are over 500,000 hip replacements performed in the United States every year. Well, there's huge economic costs, and these surgeries are very common and very widespread, and they're really, they do really work well. Hip and knee replacements are two of the surgeries that the orthopedic community, they've really perfected. And there's a lot of research, and they do a really great job with these surgeries. And the numbers continue to rise each decade. I have the good fortune of working with some really good orthopedic surgeons, physiatrists, and good primary care sports medicine doctors. And they really focus on giving people the entire picture and telling them the story of when it's appropriate to get certain treatments and to get certain interventions, because the X-ray and the MRI show osteoarthritis and they show some degenerative changes in the hips and knees, but they don't show the function. They don't show what's going on in your life. What's more important than the X-ray, and what is ultimately going to make your decision whether you get a hip replacement or knee replacement or don't get the surgery and go for another intervention, is what your functional limitations are. Can you put your socks on? That's a huge one, right? That's a huge lifestyle thing where you can't, if people with hip osteoarthritis can't put their socks on. You go for long walks. Could you sit on a toilet or sit on the train? Are you having trouble walking up and down stairs? Could you sit on a couch? Could you go for long car rides? Could you sit down at the movies for a 2-hour movie? And the movies actually, or maybe 3-hour movie, because I feel like these coming attractions are usually like 30 or 40 minutes now. Can you play with your kids or grandkids? Could you get into and out of a car? Are you having a hard time sleeping? Could you play recreational sports, which you really enjoy? These are the things that are going to drive your decision whether or not to get the hip or knee replacement. Well, the X-rays don't tell you how limited the person, and they don't tell you the function. We use them to see if there's any major red flags. Like I said before, if you have avascular necrosis or there's stress fractures or something like that, where surgery would be an emergency. But really, the imaging doesn't tell the whole story of how your life is limited. Function matters more than your X-ray. And when deciding when to get a hip or knee replacement, the deciding factor is your functional limitation and how much the pain or disability impacts your life. That's a story on arthritis and degenerative changes in your hip and knee joint. Now let's talk about pain, right? Most of the time, people are going to the doctors not because of, or maybe because of functional limitations, but more because they're in pain. So you could have pain without having any damage, and you could have a ton of damage and a ton of joint degeneration and have no pain. I always like to tell, I wasn't going to tell this until later, but I always like to tell a story about my mom. So I brought my mom to an orthopedic surgeon probably about 15, maybe even 20 years ago. Let's say 15 years ago. Oh, he put up an X-ray, and she was going because her knees were bothering her. And they were making noises, and she wanted to get something done about it. I brought her to an orthopedic surgeon. He did X-rays, he did some other imaging, and we were looking at the X-rays of her knee, and it was one of the worst X-rays I've ever seen, honestly. It was no cartilage at all. It was her tibial plateaus were they were angled, they were flat. There was like no joint space in there. All the things that you're really deciding when to get a joint replacement, she had them all. And the doctor said things like bone on bone. You have bone on bone here. You have a lot of wearing of the cartilage. But the interesting thing, I kept asking her, do you have a lot of pain? And she's like, no, I don't have a lot of pain. It swells and it makes noise, but it doesn't hurt. And then this was 15 years ago, before I really took a deep dive into understanding pain and the neuroscience on pain. I couldn't understand why she wasn't in a ton of pain. And the reality was she had functional limitations. She didn't have a ton of range of motion in her knee, but it wasn't hurting her, and it didn't bother her, and it wasn't keeping her up at night. and she didn't get the knee replacement, and she ultimately was okay. She's not that she's not that physically active, but she didn't have a lot of knee pain. And as it progressed, it started getting a little worse. And there were times that she had knee pain, but now she's almost 80 years old and she hasn't had the knee surgery. And we kind of reassess week to week, month to month, whether she wants to get it. She doesn't want to get it. So she's doing some other things. She's getting some joint injections. And overall, she's functioning okay, even though she has a lot of degenerative changes and her pain really isn't that bad. That's a situation where you have someone with a lot of structural damage and no pain. And then I see people all the time with a ton of pain and their x-rays are pretty normal. So they have a lot of pain they can't understand. So that's how the nervous system works. So let's talk about the nervous system, because pain is an output from the nervous system, and pain doesn't live in your worn out cartilage. It lives in the nervous system. The nervous system is made up of your brain, your spinal cord, and you have 40 miles of nerves that are wrapped around your entire body like thread, conducting electricity throughout the body. There are 1 billion neurons or nerve cells in your nervous system. Let's say, this is how it works. Let's say you step on a nail. You step on a nail, you have these mechanoreceptors all over your body in the fascia. The mechanoreceptors are sensors, kind of like the sensor when you walk into a store and you step on the mat and the doors open. So you have these sensors all over your body. And some of these sensors are sensitive to hot, cold, sharp, dull, pressure, vibration, stretch. There's no pain receptor. They're mechanical sensors. So what happens is you step on a nail and some of these sensors go off. Maybe the sharp one goes off. Maybe the hot one goes off. That sends a signal to the spinal cord. And then your spinal cord sends a signal up to the brainstem. And in your brainstem, we can think about that as an alarm box. So an alarm goes off. The alarm goes off and basically says something sharp and hot is setting off the sensors in your right foot, right? Because that's where you stepped on the nail. Now it goes to the cerebral cortex, and the cerebral cortex has to collect data based on your past experience, past injuries, thoughts about nails, thoughts about feet, things that doctors have told you, things that family members have told you, anyone else has been in that situation. And then ultimately, it goes to an area in the brain called the prefrontal cortex, which is your executive functioning and decision-making area of the brain. Now, in this area, the prefrontal cortex has to get the information on if this situation is safe or this situation is dangerous. And if there's more credible evidence based on your past experiences, thoughts, past injuries, if there's more credible evidence of danger than there is credible evidence of safety, then the nervous system will create a pain experience to protect you and alert you that there is a problem. And then the important thing to know here is that the pain experience is not always accurate, and it can be sensitized over time, and it can be overprotective. Let's take that same situation with the neuroscience model of pain towards your hip pain, right? So let's say someone has hip pain and the hip is hurting them. So if we go back, there are sensors in the hip that are being stimulated. They're sending messages to the spinal cord, up to the brain. An alarm goes off in the brainstem, and then the cerebral cortex is using information like things that doctors have said, other family members who might have had hip replacements, someone who might have had a surgery that didn't go well. They also have some thoughts and emotions around things that they can't do. Maybe they're worried that they're not going to be able to run anymore, or they're worried that they're not going to be able to play with their kids, or they're frustrated that they can't go on the list. So it kind of takes all this information, goes to the prefrontal cortex. The prefrontal cortex has to weigh the danger and safety. And if there's more credible evidence of danger than there is of safety, your brain will create a pain experience with regards to your hips. Your hip will start hurting. And then the pain in the hip alerts you to do something about it. And again, the longer you have this pain, the easier it is to set off. And we call that central sensitivity, where the pain response gets really easy to trigger or set off. I see this all the time in physical therapy. We're trying to get people stronger and get people more flexible and get people to move better, but we're also trying to desensitize that pain signal, and we're trying to make people feel safer, and that's ultimately what's going to help you have less pain. To rewind, you could have a lot of pain with minimal joint damage, and you could have a lot of damage with little or no pain. Pain is not always accurate, or it may not be always the best gauge to decide whether you should get a surgery or not. Now let's talk about some non-surgical treatments for hip and knee osteoarthritis. Again, this isn't going to replace the cartilage or the joint surfaces in your knee, but it's really geared towards making you more functional. So the first thing that we're going to talk about is physical therapy. Physical therapy, there's a ton of research that shows that therapeutic exercise to improve strength and mobility are really helpful for people to improve their function. Things like resistance training, foam rolling, joint mobilization, soft tissue massage, active release, Graston technique, any type of these interventions are really geared towards getting your muscles stronger, getting you to move better, and getting the joint and tissues around it to be more flexible and mobile. Physical therapists also work with people on their gait pattern, on how to walk properly and how to move properly, and just kind of looking at the quality of your walking and the quality of your exercise. We work on doing balance exercises, movement corrections, and even recommending assisted devices to unload the joint a little bit. And then there's education around pain and activity, which is what we just spoke about. Pacing, like how much should you walk, how much you should run. And we kind of use different strategies to help people pace themselves to make them more functional. If you know you're going to be walking a lot on vacation, maybe use a cane or some other strategies to help. Then we could look at injections and procedures that helps decrease inflammation in your hip or knee joint, and they do get short-term relief through reducing inflammation. There's viscosupplementation, which is like your Synvisc or the hyaluronic acid injections. Viscosupplementation, it's like an oil can where they're injecting a lubricant into the joint to help the quality of the joint movements. The joint moves a little bit better. There's a little more fluid in there, a little more grease for that wheel. So there's good evidence that it can improve function with osteoarthritis. And I have patients who get viscosupplementation every 6 months. They go every 6 months, get an injection in their joint, and it really helps improve their function. Insurance usually covers it, and it's really not that cost prohibitive. Then there are things like PRP injections where they draw your blood and they take out some of the growth factors, and then they inject that back into the joint or into the muscle. And there's some inconsistent evidence. If you're not ready to get your joint replacement and you're looking for some other options, it has helped. I've seen it help a lot of people. There's PRP, but it is a costly option. PRP injections usually will run between $2,000 and $3,000 per procedure. There is some cost prohibitive things going on there. And then you look at things like stem cells and some other regenerative therapies. And yeah, there's some evidence, there's some limited evidence of it helping for in the hip and knee joint, but it's really cost prohibitive. Those could be up to $10,000. I just wanted to let everyone know there are non-surgical options when you're dealing with hip and knee osteoarthritis and you're not ready to get the joint replacement. So it's important to really educate yourself and have an honest discussion with your doctor about all of these procedures. And I think the best conversation to have with any doctor is expectations. All right, we're going to try this procedure. What should I expect? What are the expected outcomes? And then you have an honest conversation with your doctor about the expectations, and then you could decide what you want to do. And all of these non-surgical interventions are really geared towards function and being able to move and being able to do more of the things that you want to do in life. So now there are some surgical options that aren't joint replacements. Some of the surgical options that aren't joint replacements are these joint preserving surgeries, like a hip arthroscopy. A hip arthroscopy, you use an arthroscope or some minimally invasive techniques to go into the hip joint, and they do some things to reshape the hip joint. If you have bone spurs, there's an abnormal shape of your femoral head and neck that's causing increased wear and tear, they shave it down and they make the mechanics of the hip work a little bit better. Now, hip arthroscopies are usually performed in younger people, like in their 20s to 40s, and it's not really an option if you have any progressed or advanced osteoarthritis. There are other things, again, for younger individuals, like PAO or femoral osteotomy or tibial osteotomy. These osteotomies are usually done in younger individuals, and they're geared towards changing the mechanics of the joint, realign the femur, realign the tibia to make the joint move a little bit better so you don't get excessive wear and loading of the joints. These procedures didn't have great outcomes 20 years ago, but now they're doing them a lot better. So there's a lot more research, and there's a lot of very skilled surgeons that do these procedures, and they can buy time. But again, these are usually done in younger individuals, and they do not do these procedures with someone with any type of advanced osteoarthritis. Now, there's other procedures like cartilage allografts and microfracture, and these procedures are really geared at implanting cartilage in areas where there's missing cartilage. And these are more done for traumatic cartilage defects, areas of your cartilage where you might have a chunk of cartilage missing that happened from an injury or a fall, and they gear replacing it. It decreases the speed in which your arthritis advances. And there are knee arthroscopy, just like the hip arthroscopies, where they clean up your meniscus tears or they repair the meniscus, and they might clean up some of this beginning stages of wearing down of the cartilage. But again, they wouldn't do this procedure if you had significant advanced osteoarthritis. Now, not all knee replacements and hip replacements are the same. Let's talk a little bit about some of the different types of joint replacements. In the knee, you could have a partial knee replacement or a total knee replacement. Partial, there's 3 compartments in the knee, right? You have the area behind your kneecap, behind the patella, and then you have the medial side of the joint and the lateral side of the joint. You have the inside of the joint, the outside of the joint, and behind the kneecap. Sometimes you have a lot of degeneration in one of those compartments, but the other 2 compartments are fine. In that case, you might opt for a partial knee replacement, which is a little bit less invasive than a total knee replacement, and it keeps a lot of the mechanics of your joint, where you don't have to do a total joint replacement. Because a total joint replacement, you're now using the mechanics of the artificial joint, where a partial joint replacement, you continue to use your own mechanics and you're just replacing one of the compartments. So you could have a partial knee replacement or a total knee replacement, where in a total knee replacement, they completely replace the femoral component, which is the upper part, and the tibial component, which is the lower part, and the patella components. They're replacing all 3 components. Then in hip replacements, there is a surgery called hip resurfacing, where instead of doing the full joint replacement, they just shave down the arthritic part of the hip and socket, and they just kind of put like a cap on it. They do this procedure mostly for younger, more athletic individuals who want to, it's a little more sturdy, or people who want to stay really active and live an active. They sometimes refer to this as a fireman's hip replacement, someone who still needs to transfer a lot of load, and they want to keep their bone stock. Or they do this procedure sometimes in younger individuals. If they do need a revision down the road, it's an easier revision with less bone loss than a full hip replacement. Now, total hip replacement, there's a lot of different types. There's metal on metal, there's metal on polyethylene, there's ceramic. There's a couple of different options you'll have with the type of components they use. And they also do things like an anterior approach, which means that they do the incision through the front of the hip. There's a posterior approach, there's a lateral approach, and that you're going to have to discuss with your surgeon which is the best option for you. And that comes into, I feel like what comes into play with that decision is, most importantly, what the surgeon is most comfortable doing. And that's why you chose that surgeon. You got to trust them. And what components they use. Really, you have to have another honest conversation with the surgeon on the pros and cons of the different surgical techniques, approaches, and what type of components are being used in these joint replacements. The big question, when do you get a hip or a knee replacement? And the simple answer is when your symptoms consistently interfere with a life you want to live. It's a functional based decision. If you can't do the things in life that you really want to do, then you have to decide whether you're going to get this joint replacement or not. And it's really based on functional limitations. Oh, how is your ability to walk? Do you have pain when you're sleeping? Are you able to sit in normal chair heights? Are you able to play with your kids or grandkids? Are you able to participate in recreational activities? A lot of people will get corticosteroid injections where are you able to manage these symptoms conservatively? Sometimes taking anti-inflammatories, or sometimes maybe some of the injections aren't working. And ultimately, it depends on your lifestyle and what's getting in the way of your lifestyle. Also, a lot of times when you're limited with the amount of things that you could do, and let's say you really enjoy playing tennis and you stop playing tennis because of your hip or knee arthritis, then it affects your mood, it affects your emotional well-being, it affects your mental health. Well, that's another reason, to decide to get this surgery or not. Another thing is, are you ready for surgery, right? Do you feel confident? Some people are scared. Some people aren't ready. And there are other options that you could do if you're really scared and you can't get the surgery for any reason. And yeah, you don't want to go into this surgery unless you're ready. And that's a decision that you have to make with yourself, the best decision for yourself and your loved ones and your family members, because again, you are going to have a little bit of a recovery time afterwards, and you kind of want to make sure it's the right time for you. But I would say don't wait too long, because I see too many people. We used to tell people that wait until the very last moment that you could get it. Wait till your joint's completely worn out and you can't do anything. But the problem with that is if you wait too long, then it starts to affect your other joints. Your other knee starts hurting, or your other hip starts hurting, then your back starts hurting, and then you have some other issues, and it kind of goes up the chain. Or you completely stop running and you completely stop doing the activities you want to do, and you start to get depressed. My advice would be don't wait too long. Don't wait until the very last moment. The surgical technique and the components are good now that no matter how old you are, you're probably not going to need another revision. You go to a really good surgeon, you have some good conversations about it, and the likelihood of you needing a revision or anything, it's not very likely. This may be the last surgery you get in your life for your hip and knee, and the surgical technique with these surgeries and the advances in the surgeries, you could run, you could jump, you could play tennis, You could play ice hockey, you could ski, you could do all the things you really want to do. My advice would be don't wait too long. Now I want to talk about my hip replacement. When I was 38 years old, I decided to get a hip replacement. And I just want to kind of go through a little bit about my story. So I was an athletic kid growing up. I played a lot of sports. I played football, baseball. I wrestled. I was always jumping and running. And then in my 20s and 30s, I did a lot of running. And I always had stiff hips. When I was 28 years old, I had a hip arthroscopy because I was having some stiffness in my hip and it was bothering me. I was having some pain. It wasn't getting better. They saw a labral tear and they saw some loose bodies in there. So they scoped it and they cleaned everything out, which was good because it bought me some more time. And since that surgery, when I was 28 years old, I started running a little bit more and I was able to play sports. I was able to play golf and tennis and racquetball and softball. And I was able, would ride my bike everywhere. I would do home care visits in the city as a physical therapist and I would ride my bike or I would run to different patients' apartments. It definitely kept me active. Then about 10 years after the hip arthroscopy, I started to have more pain and more structural limitations, and I was having a hard time sitting. And I noticed that we would be eating dinner and I was always standing in the kitchen because it wasn't comfortable for me to sit down. I ended up getting a seat on the toilet that was a little bit higher. It wouldn't hurt me when I sat down. I was uncomfortable sitting on the subway because the seats were low, so I would always stand. I kept on getting different pain responses, and every couple of months I would have a few days with pain, and then it was every month I would have a few days where I was limping and having a hard time moving around, and then it was every 2 weeks I was having a day or two of pain. The pain was escalating. I was getting frustrated. I was avoiding activities that I normally would do. And I decided to talk to a couple of hip surgeons and see what the best option was. And they recommended a hip replacement, and I really wasn't ready. And the interesting thing is, when I decided I was ready, because it was really affecting and limiting my life, you call the surgeon and you schedule your hip replacement surgery. And then a funny thing happens. Your pain goes away. Once you schedule the surgery, your pain goes away. And it happens all the time. And I hear it all the time. It comes back. But again, like once you're so happy you get it done. But I was at the point where I was 38 years old. And I felt like I was really young to get a hip replacement. I was trying to wait as long as I could. And I probably waited a little too long because then it was causing some other issues. I really limited the amount of things that I did. And looking back on it, I probably should have had it done a little bit quicker, but I was trying to hold off a little bit. When I decided to get my hip replacement, it was really impacting my life and the things that I enjoyed doing. It impacted my ability to play with my kids, coach my kids' little league team. I wasn't participating in sports. And now, 10 years later, after my hip replacement surgery, I could run. I actually had a hip resurfacing because I felt like that was the best technique at the time for what I was going through. So I saw a really good surgeon, Dr. Edwin Sue, at the Hospital for Special Surgery, and he did a hip resurfacing on me. And 10 years later, I run, I go to boot camp classes, I'm in the gym all the time. I'm in so much better shape now, 10 years later, than I was when I was trying to hold off on the hip replacement. Some closing thoughts. Hip and knee osteoarthritis are common and very manageable. And having pain does not always reflect damage in the tissues. And this is another important thing that I like to say. Having surgery doesn't mean that you failed. Having surgery, if getting this hip surgery or this hip replacement surgery or knee replacement surgery allows you to do the things you want to do and allows you to be happy and play with your family and continue playing sports and be active and be healthy, we're really lucky that we have this option, and this could continue to progress and allow us to have the quality of life that we want. The goal here is really quality of life. Well, that concludes this episode. This episode is really for educational purposes only. Hopefully you got something out of it. If you would like to make a physical therapy appointment or assessment, you could reach out to us at dynamicsportspt.com. And if you want some more information on pain or dizziness, you go to pain&dizzy.com. I hope you enjoyed this episode, and I will see you next time.